So one of the emerging issues of our day is the change in public perception around about marijuana legalization. As you know, Colorado, Washington, and Oregon have now all gone green, and not talking about their environmentalist policies. California policymakers have been talking a lot in the past year or two about marijuana regulation, and they're not just blowing smoke. Last year they established in legislation a regulatory framework for medical marijuana overseen by the new Bureau of Medical Marijuana Regulation, or BUMMR. And coming soon to a shopping center near you, signature gathering for an Adult Use of Marijuana Act ballot initiative, which they're trying to qualify for the November ballot. So this is certainly an issue that's around which there's been a lot of discussion, and our next speakers are going to be addressing this issue, particularly as related to marijuana legalization and its potential impacts for our public behavioral health system. The first speaker, I'll introduce them both now, and then they can speak one after the other. But our first speaker will be Patrick Zarate, who is Division Manager for Ventura County Behavioral Health, Alcohol, and Drug Programs Division. Patrick has worked in the behavioral health field for more than 30 years. He's overseen multiple treatment programs and is also a leading proponent of community-based alcohol and drug prevention initiatives. Patrick has led a multi-agency effort to shape public understanding and policies regarding marijuana in Ventura County and beyond. These policy discussions have focused on the health and safety of youth in particular, and the concern about potential marijuana legalization impact on youth. Since that time, Ventura County has developed and launched a number of community messaging campaigns and policy briefings, and they've been sort of a model for us and other counties for how to address this issue in terms of public messaging campaigns. And then also speaking will be Dr. Peter Banys, who's a clinical professor of psychiatry at UCSF and has a 3.5-decade career in the field, including direct clinical care, clinical research, and teaching of UCSF psychiatry residents and substance abuse physician fellows. Until his return to the Bay Area last year, Dr. Banys spent 2.5 years living and working in Hanoi as a technical advisor for an international NGO assisting Vietnam in scaling up of methadone treatment as a response to the spread of injection drug use and HIV. Dr. Banys has designed a phased model of addiction treatment that's been widely adopted in the United States, and he has directed fellowship training programs in addiction treatment for over 30 years. He's also a member of Lieutenant Governor Gavin Newsom's Blue Ribbon Commission on Marijuana Law Reform. Dr. Banys is past president of the California Society of Addiction Medicine, CSAM, and has a special interest in international and California drug policy issues. So with that, we will begin with Patrick Zarate, followed by Dr. Banys. Thank you.
Oops. There we go. Good morning. Wedged in between Dr. Banys and Dr. Clark, I guess I represent the ground game because I'm really just a local healthcare administrator. But I have a lot of slides, so might as well get to it. Just a word about Ventura County. If you didn't know, we're one of the large counties, probably the smallest of the large counties, 850,000 people, and we're located along the coastline between Santa Barbara to the north and LA to the south. Also, Just a word about our county behavioral health system. It sits under the healthcare agency, which is our parent organization. It has a very robust ambulatory care system, primary care, specialty care, a couple of hospitals, including one that's being rebuilt. It's a very financially viable and vital part of our community. The healthcare agency also includes public health as well as our behavioral health system, and substance abuse disorder treatment is just a part of behavioral health. So I had a couple of thoughts about how to start this presentation, and I thought the easiest way to discuss it would be to talk about conversations that I had late in 2011 and early in 2012. And one of the conversations was with our treatment manager, who's a clinical psychologist and a research psychologist, Dr. Linda Gertzen. She'd come back from Washington from SAMHSA and a couple of conferences and was talking about some new science in relation to the long-term effects of marijuana on the developing teen brain. And she burned rather passionately in my office over the course of a couple of months in late night discussions that we had, because this had already sort of become very ubiquitous and was just something that was accepted, that we had a lot of kids in treatment that were using marijuana. Probation wasn't even testing for it anymore, et cetera. So she was very emphatic about that, and we did look at that research. It also dovetailed with a conversation I have with colleagues with other agencies that share a concern for teen health. And this person with probation said to me, hey, you know, I heard one of your marijuana commercials over the weekend, and I have to tell you, it was very inconvenient. And I said, oh yeah, in what way? And she said, well, my 13-year-old daughter was in the car with me, and it forced me to have a conversation with her that I wasn't prepared to have. And I thought, wow, that's really interesting. Here's a person who works with juveniles on a regular basis, oversees all these different programs, and was struggling with an ability to have a conversation, primarily because of the cacophony of white noise that we're beginning to hear at that time about legalization. Then probably the most motivating conversation I had was with one of our prevention contractors, who said to me that I hope you're not planning on putting any resources into this issue of marijuana, because it's already asked and answered. It's going to be legal, if not in 2012, certainly by 2016. And that was very motivating for me. I like a challenge. But at the end of the day, it really isn't about legalization, and it's not about prohibition. It's about what the science says and what the impact is on developing teen brain. But we like to look at things locally. So despite the national trends, some of which you are very familiar with, we decided to take a look at how marijuana manifests itself within Ventura County. So within our adolescent treatment population, now as then, almost 3/4 of the kids that we admit into treatment report marijuana as their primary drug problem. Going a little bit deeper, we can see that the age of onset's fairly young. Average age is 13. People reporting that marijuana was their first drug of use at all was close to 50%. And then when you combine that with the group that said they were using marijuana and alcohol initially, it was 75% of our population. But you could say individuals who are admitted to drug treatment programs, well, of course they're going to have access to marijuana, they use drugs. What about in the broader community? So one of the things we are kind of unique in Ventura County is we're one of the few remaining counties that runs its own DUI program. And when you run your own DUI program, you have the ability to tell them what to do. So about 10 years ago, I asked them to start collecting exit data. And so we've been collecting what we call place of last drink data for the last 10 or 11 years. And we took a look at that between 2009 and 2014. You can see that 9% of the people coming into our DUI program report they were using something other than alcohol at their time of arrest. And we saw a rise over that 4-year period of time from 7 to 11%. Ages 18 to 24 were disproportionately reporting that they were using drugs, and the two most common drugs that they were reporting being involved with were prescription drugs and marijuana. Although with the prescription drug, that's usually, you can see that's an older age group, and with the marijuana use, it's that 18 to 24-year-old age group. So we also looked at, how often are these individuals being involved in potentially life-threatening incidents. And you can see from the bottom bar graph all the way up to the top that as you add things to your DUI day, other drugs, you're going to be perhaps more likely to be involved in a vehicle accident. And how serious are those accidents? Well, the folks that have multiple drugs on board are more likely to be involved in an accident that involves both personal injury and property damage. But if you know anything about impaired driving, you know that a DUI is very common and a DUI arrest is very rare. So we took pains to do a local digital survey and asked about what people's behaviors were in relation to getting into vehicles and being a passenger with someone who might be under the influence of alcohol or marijuana. You can see that young adults were more than twice as likely to have been in a car when the driver was using marijuana. And you could say, well, that's just a DUI. We did a little bit deeper dive on the folks who reported using marijuana and other drugs, and you can see that the average blood alcohol content is almost twice the legal limit. You can see that 75% of those drinking alcohol in addition to using marijuana were binge drinking on the day of their arrest. You can see that 19% of those who indicated they were using marijuana and alcohol were using drugs on top of that. And you can see that they drove some distance. Over half of them were driving an average of 4 miles or more, and 38% had a passenger on board. So if you think about the age group that we were concerned about, youngsters, 15 to 20, if you look at the CDC charts for the most common reason for death in that age group are motor vehicle accidents. So it's not just a DUI. But we also looked at the California Healthy Kids Survey data in Ventura, and I'm sure you're familiar with that survey, working with the Ventura County Office of Education over, it's conducted every couple of years. So looking from 2006 through 2014, you can see that the use pattern certainly scaling up. Just under 1/4 or 23% of 11th graders and 14% of 9th graders reported using marijuana on a current basis. In other words, it's already beginning to rival the use of alcohol. How difficult is it for students in your grade to get either alcohol or marijuana? You can see that marijuana is already perceived to be as easy to obtain as alcohol. How many people are reporting that they're using or that they have any perceived risk with their use? Only 1 in every 6 high school juniors perceives that occasional use is risky. Going back to our community survey, we wanted to find out from adults what they thought about it, and you can see that at least in Ventura County, there's a substantial number of parents that are concerned about frequent and teen marijuana use. And just if you haven't seen this before, when it comes to perceived risk, that is a big deal, because there are studies like this one from the University of Michigan, which has been done for quite a few decades, called Monitoring the Future, that shows that there's a strong inverse relationship between perceived risk and marijuana use. So why do we care? Well, we care because of the long-term and potential cognitive impacts on kids' brains. And I believe there's an animation that goes with this. Do I have to press? I do.
Marijuana and your kid's brain. Marijuana is much more potent than it used to be. It's 3 times stronger than 20 years ago. Locally, it's often 5 times stronger and continuing to rise. Effects include slower reaction time, shorter attention span, poorer memory. Teen brains aren't the same as adults. They're still developing. During this major stage of brain development, the connections get stronger so that information can travel faster. This leads to better decision-making and better control of emotions. But using marijuana frequently as a teen can slow or even stop brain development. Stopping use as an adult may be too late. The major phases of brain development are complete. Changes can be permanent: slower processing speed, worse problem solving, low verbal comprehension, less control of emotions, poorer memory. IQ can drop up to 8 points and not rise again. This can lead to lower grades and fewer options in life. For instance, teens who start using marijuana by age 15 are almost 4 times less likely to get a college degree. So how common is marijuana use among teens today?
Okay, I'm going to stop the video there because the sound is running way ahead of the animation, but it goes into issues of academic performance as well as the potency level of local marijuana. So in addition to the effects that it would have on the teen brain, you may have seen this infographic that was pushed out by the CDC in the last couple of weeks. We're talking just Dr. Clark's presentation about the issue of opioid addiction. You can see that it triples the risk. If you're addicted to marijuana, you're 3 times more likely to be addicted to heroin. That's from the NSDA survey. And as I mentioned, there's unprecedented potency and modes of transmission that have been developed just recently, but also really kind of unanticipated. Even if you talk to the proponents of legalization in Colorado, I don't think they saw the issues with edibles coming. So then what was our response? Well, in 2012, we launched a concerted campaign to educate the public, bring up the discussion to a point to where we could possibly impact what the narrative is that we had been hearing. And certainly there's always a focus on treatment services. In the last several years, we've doubled our capacity for providing services to kids. We have a new clinic that's opening in Thousand Oaks. We also piloted a brief intervention project in the Conejo Valley School District, which has helped over 400 kids stay in school, improve their attendance, deal with their academic performance issues, as well as deal with their minor drug issues. And that not only won a Golden Bell Award from the State Office of Education and was recognized by SAMHSA with a Service of Science designation. What really excited me as a healthcare administrator, we were talking about costs, was that the Conejo Valley School District found that it was so essential that they actually voted unanimously to fund the project going forward. So we're providing technical assistance, but they're actually paying for it. And the reason that is important is because this is what treatment looks like. It's expensive, it's perilous, it's often not effective, and it's pretty rare. From what I understand, only about 10% of people that would qualify for substance abuse treatment actually receive it. So we have to do something a little bit different. And that's where the issue of prevention comes in. That's where using a public health approach is really valuable, because the goal is to not necessarily instill prohibition or to tell kids, oh, using drugs are bad and you need to stop doing that. It's really to just change the narrative, have the conversation, affect social norms and attitudes and beliefs to the point to where we could possibly delay the onset of drug use, because there's exponential benefit to doing that. If you delay the age of onset, then you possibly won't have these long-term effects on the individual's cognitive processes. If you delay the age of onset, they're less likely to be addicted and need treatment in the future. If you delay the age of onset, they're actually less likely to use the drug. So we launched a whole series of community-based education strategies, and those are across a multitude of different platforms. And we've really tried to get ahead of the technology that people use. I'm sure most of you have smartphones, and parents of middle school kids and high school kids get a lot of their information using smartphones. So printing a whole bunch of pamphlets doesn't necessarily really solve the issue. So we have been piloting this in a couple of school districts in Ventura, and of course we do it both in English and in Spanish. We do create like specific targeted campaigns. There's one that's set up for college students, for high school students, for middle school students, and helps them to really understand what the myths are that are being broadcast out there in the larger world. But all of our tools come with an instructional kit. We don't launch anything without being able to sit down with the people that we're going to be handing it to. In this case, it's school resource officers. And we go through every single item that we have, tell them exactly how it needs to be utilized, how to frame the discussion, what sort of metrics we're looking for, getting back to see how effective it is. Using local data, again, the State Office of Traffic Safety has given us a grant for the last 2 years. Hopefully we'll get one going into year 3, and talking about the fact that we really want to have an impact on those impaired driving patterns that we see in our place of last drink surveys. But although a lot of counties have had their prevention efforts contracted out, we actually have our prevention staff in-house. And one of the advantages of that, just like with the DUI program, is you get to tell them what to do. So one of the things that I said was, the stuff looks very slick, but I'm still going back to that conversation that I had with this parent, which is very similar to other conversations I've had with parents. I want something that really resonates with those young parents, something that really captures, what it's like to be a parent of a kid in Ventura County at this point. So we engaged a design and marketing a company called JAMS, which is located in LA and has done a lot of work within the LA media market and in Hollywood, and said these guys really know this demographic. If you know anything about Hollywood marketing, you're talking about 16 to 20-year-olds. That's who you want to buy tickets. So we launched How High Ventura County at the end of 2014, and it really was to help parents to have that difficult conversation and to get some facts about things. One of the more fun elements of the website is what's your high Q? And so this is a test that they can take. It's very interactive, and they can post their results, they can share their results, but basically they get to test their wits on weed, because this isn't the marijuana of the 1980s or the 1990s that we're talking about. We're really talking about a completely different form of this agent. So our marketing, our prevention efforts are intentional, strategic. It may seem obvious, but kids are very highly connected, so are their parents. So rather than just throwing a bunch of stuff out there and saying, hey, take a look at this, we'd really think you would really like to have this information, we really focus on understanding the current context, the target audience, and making it fun and engaging. In addition to the fun part of it, we also have a project plan for every single prevention strategy that we put out there. And one of the things that we came to understand is creating a buzz, pardon the pun, but putting something out there and timing the dosing of it, pre-releasing something, getting the media interested in it. So we have those sorts of charters. And then when we actually walk onto a campus or something, we try to use those marketing techniques that we see in the LA media market that makes it fun and engaging for individuals to interact with our materials. one of the key things about this particular thing is really understanding the channels of activation. So there's getting the earned media, and it's great. We've got on the front page of all the different print media in Ventura, but when we launched this thing, we deliberately launched it in Thousand Oaks because we wanted to have access to that LA media market. It's one of the biggest media markets in the country. So we did that, as well as really gained an understanding through our contractor of all the different ways that we could get this thing to be seen across the electronic medium. So they totally understand how to use web-based analytics, but it's not as simple as just saying, oh, you know, somebody liked me on Facebook or reposted it on Twitter. It really is understanding the new social media platforms and doing the push. So 3 weeks after launch, they sent me a report where they showed across all of our media channels, we had 4,700,000 media impressions. And from my standpoint, although all of that cost a lot, that really resonates a lot more than handing out 2,000 pamphlets to people that are never going to read them. How do we know our messaging works? Well, we have a couple of signature prevention strategies that we've used in the past. Social host ordinance. A decade ago, we were the first county in the United States to have all of our municipalities sign on to social host ordinances. And now we know that from the data and the impact studies that we've done, that in the municipalities where it's being aggressively utilized, those calls for service to underage drinking parties are way, way down. Same thing with our prescription drug disposal program. We took that to its next iteration, so How High Ventura County, and reformatted the message so that we could actually not just talk to the parents, but also talk to the kids. And probably every month, I get notes from educators that are telling me things like the students really enjoyed the presentation, they thought it was hip, they could totally relate to it, it was compelling, they weren't told to just say no, the students were presented with the information and treated as intelligent individuals who could process and do critical thinking. So, kind of summing up a little bit, efforts should be data informed. It's all about raising the profile of the problem, having that public dialogue, and getting key agents to join us with their resources to help to reduce this problem. And one of the ways that we did that, and you can pick up this brochure outside in the foyer, is I've asked staff in parallel to all of this media stuff directed at parents and kids and educators and SROs to do issue briefings and publications over the last several years. And so we had a conference in January where we brought together cities and county officials, city planners, city attorneys, code enforcement, first responders, elected officials, et cetera, so that they could look at and consider policy decisions that they might need to make, or at least weigh and balance on 5 different domains within the community. So one of those being business community. What does the advertising, what will that look like? Are there security risks for a cash-only business? What about adjacent businesses? What about the different types of traffic that's going to bring into a downtown area? What about neighborhoods? Are we talking about complaints already about people growing marijuana in their backyard? Healthcare, obviously, we talked heavily about that, the impact potentially on behavioral health, not just on substance abuse, but on mental health. And the environment. I have to say that it's really interesting to be in a marijuana work group within our county and be having conversations with the agriculture commissioner. I mean, this thing, talk about green? No. We're talking about pesticides, we're talking about fungicides, we're talking about a real impact. And Ventura is a water county. If you've ever taken on the Surf Rider Association, you know what I'm talking about. This is something that's very, very important to us on a local level. So yes, there's standing room only. So the takeaway for us and that we wanted to share with them was we need to learn from the lessons that we've already know from tobacco and alcohol policy. And those might be things like limiting access, restrict age, use local controls. Those are constitutionally protected authorities that these local officials have, and they should use them. Restrict advertising, retain smoke-free policies, and certainly fund prevention efforts. 77%, this is a headline from a couple of weeks ago, 77% of teens now see smoking marijuana as, quote, totally safe. That's based on a SAMHSA report. And what this really tells us, going back to the prevention stuff, kids don't live in a bubble. And as more states begin to go toward or talk about having medical marijuana or legalized marijuana, it creates a public perception, including amongst our youth, that it's safe. And just because it's legal, not safe. Not for kids anyway. And this is just another slide that shows that over the course of time, you can see with the 8 states that were tracked here that had medical marijuana, that usage amongst teens has actually gone up. How will it impact our public and behavioral health system? I think we should approach this with an abundance of caution. And the infographic didn't come up. There's a report card, take my word for it. Vermont, the state of Vermont did a sort of a meta-analysis on the academic research, the social research, different health reports on what the impact of marijuana would be on a variety of different health indicators, not just on behavioral health. And in most categories, the impact is the situation will become worse. In some, it's still unclear, and I certainly want to say that not all the science is in. Certainly, people drawing conclusions from Colorado right now, it's probably too early to tell. So, in conclusion, last slide, Tom. In behavioral health, we don't just need the money; we need the science and we need the time, and that's why we started laying track early. This isn't a lean back situation, it's a lean forward situation. Even if it's just to have the conversation, that's something that we need to do locally. We can't sit, if we look at this thing as something that we're going to sit back and wait for a sovereign to come down and say, here's what you need to do, that's just not going to happen. We don't necessarily have that luxury. You can look at anything that's been pushed out into our area. AB 109, prison release. Hey, counties, you guys figure it out. Some people get money for programming, some people don't. When we set up funding, we must do so with the full spectrum of the need in view, including all those different aspects, and the challenge and the opportunity is to learn from alcohol and tobacco that came before this and set the highest possible standards for protecting our youth. Thank you.
How do I get my slideshow up? Ah. Magic. It worked. I'll try to get this in 30 minutes. So I will not be reading slides to you. I urge you to do that yourself. I start with the assumption that the polls are correct, that in November we will have marijuana legalization in California and join Oregon, Washington, and Colorado, probably also Hawaii, Arizona, and Alaska. So the West is going green. And we have to ask the question, what can we do in a constructive fashion, rather than an ideological fashion, to respond to the issues that legalization will present us with? And there are a number. So I will emphasize my recommendations, or Tim Cermak and my recommendations for agencies in the state of California. The landscape is changing. We are in the middle of a paradigm shift that's quite substantial, not just in America, but internationally. Basically, in America, we've had a war on drugs for a century. Various permutations of a war on drugs, but we've had a war on drugs ever since the early 1900s. Internationally, we've had a war on drugs for at least 50 years, and I think a reasonable case can be made that the war on drugs is a massive and sustained failure for its stated purposes. So that the evolving landscape poses previous ideas and newer ideas. It's not entirely either or. There's a lot to be said on both sides. But there are alternate and additional concepts. And in the field of mental health and addiction, of course, harm reduction is one of those. And it took the federal government until, 2 weeks ago, to allow needle exchange. One of the most evidence-based practices for safety and health that we've ever had. But evidence is no match for ideology. Cannabis and marijuana. Cannabis is the basis for what I call soft and hard defections from international conventions, and for outlaw international and domestic drug policy reforms. So let's look at that. There have been a lot of soft defections internationally, lots of policy papers, lots of blue ribbon commissions and panels that have written about marijuana and cannabinoids, and have basically taken the position that Mayor LaGuardia's commission took in 1937, that it was probably not more dangerous than alcohol, not entirely safe, but not in a class with heroin and other major drugs. So this is old news, and it hasn't particularly influenced either the international war on drugs or politicians. But that's now changing. We have hard defections from the international conventions, and again, these began internationally. They began in other countries, not so much here, but the USA has joined this in essentially medical marijuana, which I consider, look, I think there are some significant number of people who need medical marijuana. I also think it's fair and honest to say that it's also a Trojan horse for recreational use. It's an access point for recreational use for many people. So the USA has really become a hard defection site in many states that have gone from medical marijuana to now legalization, which is what we're facing with ALMA, the Adult Use of Marijuana Act, on the ballot in November. So where's cannabis and marijuana used worldwide? Well, in the most industrialized countries for the most part. Although I can tell you, having been in Southeast Asia, that it's gaining headway among the elite young, along with ecstasy. So these are becoming popular drugs, probably through media. Since 2011, over half of Americans favor marijuana legalization. How come? Well, I think there's a pretty good reason for that, which is about 43% of the US population over 12 years old has a personal use history of marijuana. They've tried it, they've used it. They smoked but didn't inhale. And they find it difficult to take seriously the demonization of this drug, which has for decades served as low-hanging fruit for criminal justice. When I was on the Prop 36 panel with Kathy Vett, I was having lunch with a narcotics officer, a wonderful man, and I said, why do you guys spend so much time chasing people with marijuana when California is awash in the highest grade heroin and methamphetamine that I've seen in my entire career? And we're sitting in Hamburger Mary's, and he kind of looks around to make sure his colleagues aren't there, and he says, well, Peter, they don't shoot back. All right, so now this is a public issue. You know that something has changed when National Geographic puts weed on the cover instead of somebody grinding millet, in Africa. I guess these are the new farmers, the new subsistence farmers. Let's look at incarceration for a minute. I've come to believe that the healthcare industry, that is treatment, my industry, competes for the same raw materials for processing, that is drug users, as the incarceration industry or criminal justice. In other words, we have two forces that want the same raw material, and we want to make them better. They want to make them better with their methods, and we want to make them better with our methods, and sometimes the methods overlap, but quite often they don't overlap enough. It's a growth industry still, although that's changing, particularly in California. The United States has about 2.2 million adults in the largest prison system in the world per capita, 5 to 10 times greater rates of imprisonment than elsewhere, including China and Russia. It's an unprecedented rate of incarceration. Is it entirely on the back of drug arrest? No. There's also mandatory sentencing and 3 strikes and other things that have contributed, but drug arrests are a huge player in this. The lifetime risks of imprisonment are disproportionate. It's an entire talk to talk about how disproportionate it is and how vulnerable various minority groups are to arrest in America. But black men are the single most vulnerable group. And let's see, who are the least vulnerable? I guess that would be white women. Okay. So this is a graph of the correctional population up until 2010. It's still about 2.2 million, but you'll see that we have about 2.2 million in custody and about twice that in some form of supervised system, probation or parole. So this is over 7 million people essentially in the supervisory or in custody part of our prison system. As I said, a lot of this is due to drug offenses. This is a chart that looks at the difference between 1980 and 2011 to show you that drug offenses really made a big difference. Let's look at California. I think California is making incredible strides in reducing the prison population and reducing the issues that will get you a charge. We've been forced through everything from federal receivership to just good public policy thinking to begin to rethink how many people we want to keep in prison and for how long. So we're making progress. But I'll tell you what got our attention. I used to think that to make big change, you had to be rich as a state. Now I think to make big change, you have to go bankrupt as a state. Because it turns out that a year in a California state prison is $60,000, which is kind of on a par with Stanford University. So this is expensive business. And it's a huge part of the budget. It's one of these entitlement budgets that you can't do too much about. And believe it or not, part of the incarceration budget in California is off the books because it's contracted out to other things. Third point, what about interdiction? What about stopping drug trafficking and smuggling and all of the rest? There are 3 monographs on this slide that will argue the point from an economic point of view that you can double, triple, quadruple, quintuple the cost of production at the farm level for drugs like marijuana and cocaine, and it has almost no impact on the streets of LA pricing. The markups are so astonishingly high that you can do almost anything you want in the source countries to make it more difficult and more expensive, and it will not change the street price very much. If you're interested in this, these are the 3 monographs that I recommend to you by economists. Having said that, so much of the cost of drugs like marijuana is tied up in the cartels. What happens when you legalize? This is a slide produced by the London School of Economics study group that shows what they call the tax gap. The tax gap is what you theoretically can recover from the street price of a product once you legalize it and tax it. Rather than giving that money to the cartels, you find some way of returning it as tax revenue. Having said that, if you make it too high, people go back to the illicit route or to medical marijuana. You make it too low, you leave money on the table. This is one of those things that the Rand Corporation and others are doing some serious thinking about in California. All right, let's turn to teenagers, the single most vulnerable group of marijuana users. There's a great deal of, in my opinion, exaggerated propaganda about the dangers of marijuana and a great deal of exaggerated propaganda about the medical benefits of marijuana. And as is true for so many things in life, the truth is much more in the middle about both. So it is true that kids see marijuana as safer than cigarette smoking. That's probably true. They smoke less of it, even if they smoke every day. But putting tar in your lungs is still not a very good idea. But we need to focus on the regular and heavy users, and I'm going to show you some intriguing slides about that in a few minutes. If we look at the various great surveys that happen periodically in America, we see that regular marijuana use, which is past month use, is a reasonable proxy for a regular user. It's been shown again and again to be a reasonable measure. It's hovering between 20 and 25% these days. It is not at the level of the 70s by any means, but it's, it's up there at the 20 to 25% level, depending on where you are. More 18-year-olds smoke marijuana than cigarettes for the aforementioned reasons. And those lines crossed back, I don't know when, 2009. Now, here's the data that I think is really important for us. The California Healthy Kids Survey. You ask the kids during the past 30 days on how many days did you use alcohol and how many days did you use marijuana? And the answer is that 3% of 11th graders use marijuana 10 to 19 days out of every 30. These we would call regular users. They're probably, for the most part, close to daily users. And an astonishing 8% of 11th graders in California use marijuana 20 or more days. These are almost certainly daily users. So now we have 11% who use 10 or more days out of every 30 in our high schools in California. It's not a treatment population. This is not Patrick's DUI population. These are high school kids in California doing the survey. So what I did was I built this table by going to the Department of Education tables for enrollments in California. And we looked at the 2015-2016 high school enrollments and multiplied the enrollments times the percentages. And what we have is we have 267,000 kids using 3 or more days out of 30. We have 179,000 using more than 10 days out of 30. And we have 131,000 using 20 or more days. So what do we have here? We have a substantive base of regular and heavy use kids at a time when they're most vulnerable. Vulnerable for what? Let's look at that. So, what are the medical harms? My thesis is that the risks to education are greater than the risks of addiction and are greater than the risks of brain damage. But the risks to education are substantial, and they occur precisely at this adolescent phase of school. And to me, that has implications for what we need to do. I'll preview this by saying we should treat schools as the workplace of youth, and we ought to have more student assistance programs analogous to employee assistance programs. Kids are employed in school, and we need to help them stay in school, and we need to help them perform, and we need to help them remember things so they can pass tests and learn. Risks for addiction. Yeah, you start early, your risks for addiction are greater. The more you use, the greater your risks, for sure. So we need to talk about delay. The longer you delay, the more protection you give yourself from the risks of addiction, not to mention the risks of impairing your learning or school retention. Well, what about psychosis? There's no question that heavy marijuana use is associated with psychotic symptoms. The big question is it an independent factor? Is it a secondary factor? Is it release schizophrenia? Because this is the age where schizophrenia emerges spontaneously. Is it a releaser? Is it a primary psychotogenic drug? Or is it, as I had in one of my cases, a kid who was schizophrenic, becoming schizophrenic, used marijuana to try to tamp down his thought disorder. So there are a lot of possibilities. But the truth is that psychosis is rare, even schizophrenia is rare. Doubling the rate, which is probably the best estimate, is still a low rate. So the game isn't going to be played around psychosis. It's something to think about with psychotic kids, but at a public policy level, this is not where the game is going to be played. Early use does make you more vulnerable, no question about it. Delaying until your 20s buys you a lot of statistical protection from what's going to happen. You start using at, well, I won't read the slide to you. Let's just say the earlier you start, the earlier in your teenage years, the higher your overall risks. If you can delay into your 20s, statistically, you're in much better shape. So my thesis is that safer is not the same as safe. It is safer than lots of things, but it's not entirely safe. It's a drug. And right now, in many cases, it's a fairly impure drug that you smoke rather than eat or get in a refined form. Although what we've learned in Colorado, which nobody really expected, as Patrick mentioned, is now that you can get these highly refined products that can be 90% THC, these extracts. And that's changing the ballgame to some degree, and probably going to change the science as we watch what happens when kids start consuming high potency stuff. Brain maturation's been talked about. Cognitive dysfunction, lots of studies, increasingly well done studies. I think some of them are misrepresented in the propaganda. But having said that, these studies do show cognitive effects. Cognitive dysfunctions that are fairly persistent and very closely associated with heavy and regular use. It's much harder to show cognitive deficits that are sustained when you're not using for the lighter weight users, but the heavy users do show sustained problems. The lifetime addiction risks, I think be careful when you see these numbers, 9% of adults and 17% for kids. These are lifetime numbers. You know, I had a lifetime risk for zits, for acne, but I don't have them today. So you have to ask the question of what's the residual? What happens to the kid who has a period of addiction? How long does it last? Does he grow out of it? And there is some data to support maturation out. Having said that, you don't tend to mature out until your 20s if you're addicted as a teenager, and those are your prime education years, which brings me back to my thesis. That risks to educational progress are arguably greater than the long-term risks of addiction or of psychosis. And these are the things at a public policy and a community level we need to tackle right out of the gate, and we have methods to do it. We don't have to reinvent the wheel. We know how to do this. We know something about student assistance programs, and we know a great deal about treatment. Having said that, we have some student assistance programs in California, and we have almost no public sector adolescent treatment programs for addictions. What we have is, on the one hand, what rich people can get by sending their kids to wilderness camps and therapeutic schools and private psychiatrists, and what poor people get, which is juvenile hall, probation, and judiciary linked treatment, which I've tried to look into, and I find kind of opaque to find their data. So what do you have? You have cognitive inefficiency during periods of use. Don't need to be addicted to know that it ain't good for your thinking squash. There is an ongoing academic controversy about IQ impact, and is it just in the heavy users or is it in everyone? What are the structural brain changes associated with regular use? I won't get into that. That's a whole other day, really, because it's a very important area of measure. I will say that the NIH is mounting a long-term, multi-decade study called the ABCD study, which is going to do prospective following of youth for decades to see what happens to their cognition, their brains, their development, and so on. Marijuana use during the school years is very closely associated with poorer academic performance. Your grades aren't as good. You have higher rates of school dropout, and you have a great number of associated behavioral and family problems. Now, this brings us into the confounds. What it means is that marijuana users don't just have marijuana. They use other drugs, they drink, they have family problems, they have social class problems, their parents may have employment problems. It's a big goulash. It's a lot of things going on, and the researchers have some trouble sorting it out, even in long-term studies. That's why I think we need to be a little bit patient about long-term studies. It's also why I think we need to fund research for more than 10 years, which is what ALMA funds it right now, but it expires after 10 years. 10 years is not enough, folks. You've got to have studies for the next 30 years. So one of the things that I recommend strongly is that if ALMA passes, we've got to have enabling legislation to continue to pay for research studies over a much more extended period of time. Not just developmental studies, not just to say what happens, but we need studies on things like drunk driving. What's the impact of marijuana on driving? What's the impact when you mix it with alcohol? What's the impact of an 80% potency extract on emergency room admissions? There's lots of stuff to look at, and 10 years isn't going to be enough. All right, legal harms. Yes, there are many legal harms associated with having an arrest or probation be one of the few available doors for treatment for youth. It's not that it's a wrong door. Somebody famous named Wesley Clark once said there's no wrong door for treatment. I agree with him. But there should be better doors. And I don't know that you should have to have an arrest in order to benefit from treatment in your own community, particularly if you're a kid. So lots of things can happen. Less and less now that, as you know, since 2011, marijuana possession is an infraction for everybody, including kids. So it's essentially been decriminalized in California already. I would say that a variant of the criminalization problem is the zero tolerance policies that have really not worked around marijuana in America's schools. There's a lot of literature on this. California has led the way in eliminating zero tolerance as much as possible. It still exists in many school districts, but California is one of the leaders in moving away from this because it's a failed approach. It basically kicks people out of school when really what we ought to do is keep them in school. Okay, let's turn to some interesting arrest data. Since 2011, what happened in 2011 is that possession became a misdemeanor, and felonies, juvenile felonies, plummeted. But of those, you'll see that a little less than half were still for possession rather than sales. So the marijuana possession somehow was still a substantial felony, but nowhere near what it had been before, which had been the bulk of the business for juvenile arrests before that. If we look at a little closer at the felony arrests, we'll see that the marijuana-related arrests are about equal to the total of dangerous drugs and narcotics. This is disproportionate. You really shouldn't have the same number of arrests for dangerous drugs and narcotics that you have for marijuana. It's a disproportionate kind of law enforcement. Low-hanging fruit, I think. This is, to me, the most interesting, which is juvenile misdemeanor arrests between 2008 and 2013. Again, these dropped in 2011, but we still have close to 6,000 misdemeanor arrests for marijuana. And it's a little bit unclear to me why in an infraction era we have all these misdemeanor arrests. And one possibility is upcharging. Upcharging is where you find a reason to say that there was an intent to distribute. Once you have an intent to distribute, of course, what do kids do? They buy, they group their money and they distribute. So I couldn't find this analyzed. I think we just need to study this and have the Attorney General's office have a closer look at what all this is about and what the charges are based on and so forth. We just need more granular information. Now I'll just turn to conclusions about implications for public policy in California. I think we need no public initiative can think of everything. We're going to need some regulatory changes after ALMA passes, if it does. Right now, the polls say 56% for passage. That could change, but that's what the polls are saying now. I think we need to fund school-based student assistance programs. I think, and this is where you're so important, we need community-based treatment programs. I don't mean probation, I don't mean DUI, I mean community-based treatment programs. And we have to invent these in a landscape where there are very few of them, and the many that have tried have a lot of trouble surviving. I know how much trouble Thunder Road has had surviving in Oakland, for example. I will say at this point that CSAM, California Society of Addiction Medicine, has formed a task force that I'm chairing to write a white paper on what constitutes state-of-the-art addiction treatment for juveniles in California, and we'll be working on this through the rest of the year. One of the things that I'm interested in collecting is information about model programs that are community-based, public sector programs, and I'm interested in collecting data on what various counties have in terms of their resources. And I'm interested, frankly, in data that says you don't have very much if that's the truth. Because I think we need to tabulate the landscape. We need to see where we're starting in order to know better where we're going. And I hope by next year early, we'll have some expert opinions about what state-of-the-art treatment ought to look like. Because there's money coming down the pike, folks. 60% of tax revenues are devoted to youth in Alma. And I don't want to see happen what I saw happen with Prop 36, which is a new California gold rush from entrepreneurs who are looking to dial for dollars. I want to see really good evidence-based programs that are community-based, solid. And I think you're the players that are going to make that solidity. So let's collaborate. Let's get some data together because we need to help the state spend its tax revenue. Remember the tax gap? All right. Let me just say that there are many models of student assistance programs around the country. This is not reinventing the wheel. I'll mention one that is SAMHSA approved. It's called Project Success. Started on the East Coast. We have a number of them here in California. I will say also that there are a couple of model SAP programs in Ventura County. And if you want to read about SAPs, one of the briefings in the Blue Ribbon Commission that Tim Cermak and I wrote is about student assistance programs, and we've pulled some notes on a couple of the California programs for you. Specific recommendations. Department of Education, educational issues. I think we need to continue to seek to eliminate as much as possible zero tolerance policies for marijuana use and possession. and try to move those kids into student assistance programs with peer support, counseling, and other resources, including cognitive and learning assessments. I think a student assistance program is not just renaming a bunch of counselors. We've got to deal with helping them with their educational performance and their learning disabilities and so forth. And I think that people who structure these programs need to have some special training in learning assessments as well as addiction and adolescent psychology. On the legal side of the fence, I think that we need more clarification from the Attorney General's office about the nature of charging for possession. Kids will be the only people left for whom possession is illegal. And so we really need to be clear about the difference between a misdemeanor and an infraction and a felony, and what leads to what, and what in particular leads to probation in the juvenile system. Two, we need to track these. We need to track infractions. Right now, I couldn't get any data on infractions. Infractions are like parking tickets, and they're really not kept in any systematic way. But if marijuana possession is an infraction, we really ought to track it in this era. We need a better analysis of upcharging. I don't know how much goes on. I don't know whether it's mostly useful or mostly destructive. I just don't know. And I think that we need to ask people who do know to look at this. We need to look at the outcomes of criminal justice treatment. We need to see what their recidivism rate is, what their relapse rate is, how they do a year, 5 years later. We need to ask all the standard questions of their kind of treatment that we ask of our kind of treatment. Not prejudice ourselves in thinking that they don't know what they're doing. Kids take a lot of leverage. Kids don't want to go to treatment. Sometimes you need that kind of leverage. But I don't know whether we overdo it or not. Recommendation 3, healthcare services, Department of Health. ALMA has a DHS advisory board. However, my reading of ALMA is it's unbalanced. It favors industry. It minimizes treatment, teachers, and parents. I think it needs to be rebalanced away from industry promotion and rebalanced towards other constituencies. In addition, that was the ALMA has that, the unbalanced. I recommend a second advisory board for the Department of Health to help advise about things like how to design treatment for the community, how to monitor outcomes, how to find out what you're getting for your money, and so on. But I think it requires an advisory group with some chops. I think we need to develop community-based treatment, public sector, and I think you're the people who are going to help us do that. Who knows better than you what it ought to look like? And I think that we've got to get organized about that. And finally, I've said already, we need more research. 4, from the medical side, we've had 20 years of medical marijuana. I think it's time to rationalize that system. I think that first, we should not build recreational marijuana dispensaries in the same dispensary that has medical marijuana. ALMA does that. ALMA essentially promotes a vertical integration, which is, I think, a huge mistake. I think we should separate them, the medical patients on one dispensary, and in another location, recreational users. Different tax structure, different cost structure, separate them out. Let's not keep using medical marijuana as a proxy for recreational access. I think that we need to convert from a recommendation system to a standard prescription system with all of the things that that means for doctors. It means you got to do responsible exams, follow-ups, refills, etc. Let's go away from recommendations and make it medical marijuana prescriptions. Having said that, those prescriptions ought to be tracked by Cures, which is the pre-existing database that tracks other abusable or potentially abusable drugs like painkiller opiates, sedatives, and stimulants. And finally, this is the one that might have to talk to the ACLU about. Tim and I think that kids need extra protection because they're the last illegal group, right? And right now, the patients Tim and I have seen call medical marijuana cards get-out-of-jail cards. And they all know how to get one of those from a pot doc. So we think that to give a kid under 18 a medical marijuana prescription ought to require A, a parental notification, and B, a second opinion from a family physician or family pediatrician. These are the references that I urge you to look at. The student assistance stuff is in the briefings posted by CSAM and also by the Blue Ribbon Commission. The single best treatment guide I've ever found, and I really went looking, comes out of Australia, where they do a lot of community-based treatment, by the way. So if you want to look at what a really well put together guide looks like, look at the Australian guide. SAP models, there's an entire agency in California that can help you with SAPs. And SAMHSA has published on that as well. So I'm going to stop here before I rattle on anymore. Thank you for staying overtime with me.
So we have a few minutes for questions. If anybody has any questions, we have mics up in front. Also, we apologize for not having a screen on this other side. I think there's going to be one put up there after lunch. So, so either for Patrick or for Dr. Banys.
I have a question for Dr. Banys. Could you tell us very briefly what research says about how legalization of marijuana use will impact both the supply and the demand for harder drugs? With the supply side, how it's going to affect the shifts that the cartels will be making to maintain their business.
You know, I don't have that. Did you all hear the question? What? Okay. I don't have the answer to that memorized. I can tell you who's done the most on this, and that's the RAND Corporation in Southern California. They've actually looked at this fairly closely, but they're guessing too.
Yeah.
And part of their issue is what happens if you tax it too high. Do you drive some of the market back to the illegals or back to the medical marijuana dispensaries as your access point? So I don't really know, everybody agrees that part of the job is to drive the cartels out of business. That is the international cartels. Now, we also have marijuana growers in Northern California who are not necessarily too happy about this legislation or this initiative because they're afraid of big agro and that somehow they'll lose their place in the market.
Well, more specifically, there is speculation that there will just be a greater focus on supplying heroin and other drugs if the cartels can't make a good business from marijuana.
I don't know. Maybe I would say there's no shortage of heroin in America.
Yeah.
One reason why I keep saying the war on drugs is a failure, it hasn't reduced the price, hasn't reduced the supply, and the purity has only increased every decade. So it's very hard to say that what we've been doing is working, and I don't think that we have a shortage of heroin. One reason why we have a number of people moving from OxyContin, a prescription drug, to heroin is that it's cheaper. In some cases, in some locales. But I just don't have enough data in my head to give you a sensible answer.
Thank you.
Other questions? Yes.
Hi. Has there been given any thought to the fact that the selling of marijuana is black market employment for a lot of black and brown youth, and how the legalization will affect that piece?
Patrick, that sounds like a good one for you.
Actually don't have any information on it. It's a fascinating question. That's a great question. Don't have any information on it. But going back to the last question, it's interesting to note that, part of the cannabis industry talking points, and there's certainly propaganda on both sides, I guess, for the overcommitted, is that we need to legalize it so we can regulate it so that we don't have these cartels anymore. If you weren't aware of it, there is a case that's coming before the Supreme Court where some states' attorney generals are suing the state of Colorado because it actually is creating a black market of drug trafficking into their states.
So we have time maybe just for one more question, if there is one. Don't see it? Well, let's thank our presenters again.